Okay, but yeah, as I said, I'm James Richards, just one of the doctors at Dorset County Hospital, and I work quite a bit in the Parkinson's service there. And I've said we're always very grateful to Parkinson's UK because they provide a lot of information for people either newly diagnosed with Parkinson's or possibly getting a diagnosis of Parkinson's. And I was just talking to one of the team here about the newly diagnosed. Oh, sorry, can you hear? Is that a bit better? Oh, sorry. And the newly diagnosed packs. So when I think it's probably quite a nerve-wracking experience coming to a clinic and potentially getting a new diagnosis of a condition. And we often found that people would see what a member of the team and they get a diagnosis and they don't really see anyone for a good few weeks or months after that. And actually having someone locally to either to speak to, but also some information from Parkinson's UK is really valuable, just on what the condition may look like in the future, who to go to for help, and what resources are available, because that's such a key thing. And I think we're really lucky to have Parkinson's UK, really, just because it's lots of conditions that we deal with don't have such an active organisation to help with that. So, and can everyone hear okay and things? And I might just bring the chair and sit down if that's all right. Oh, excuse me. So I thought I'd just talk a little bit about some of the things that we've done in Dorset County Hospital, and some of the things that we're trying to do, and then perhaps some of the challenges that we've had in just getting certain things implemented, and then depending on what works best, either just have a bit of a question and answer session, talking about any questions people have, and any things that I think probably one of the most important things I get from coming to these meetings is actually things that people find don't work all that well, and or some of the service parts that don't really serve people with Parkinson's as well as they should do. There. So, and any questions or any things that people would like to discuss in the next sort of 20 minutes, half an hour? No. Yes. Oh, yes, sorry.
We're here in Lyme Regis, we sort of live on the cusp of Dorset, East Devon, and a little bit of Somerset.
Yes.
And lots of people, some of our group certainly can have problems with their nurse maybe in one county and their consultants in another county.
Yes.
And the two don't seem to talk to each other. And making that change so that it works, or finding two people in the same county, seems to be quite a difficult battle.
Yes, yeah, and I think that is such an important point, because really with the Parkinson's nurses in Dorchester, we've really struggled for a long time actually with having enough in the way of Parkinson's nurses. And Parkinson's UK originally set out some guidance that people should have I think it was about one Parkinson's nurse for 300 people who have Parkinson's, but actually in a rural area. Yeah, well, and that's fine in Bournemouth, Poole, London, where people are quite close together. But in more rural areas, they said actually more like probably 250 to 200 people who have Parkinson's to one nurse. So, and we've had about one nurse for about just over 500 patients. And as you can imagine, that's just not enough, really. And I think one of the biggest struggles has been appointing Parkinson's nurses, but also getting the hospitals and the trusts to fund and organise posts. And that's, I think, the team here and Heidi as well from Parkinson's UK they've been really helpful in just pushing the hospitals to appoint Parkinson's nurses. And we have now got I think we used to have one nurse covering Blandford area, Shaftesbury, Bridport, Lyme Regis and areas, and now we've got two. So there's Carol Walker and Lisa Green, and Lisa's just been appointed quite recently. So that has been a big benefit for us, because that's really helped with the staffing. Because really, you can imagine, it's quite a complex condition, and you need a lot of input, not just for the motor parts of Parkinson's, but also for the other areas like mood, anxiety, bowel care, bladder and bowel issues, and all these other things that need help. So that has been a big benefit. So I think, oh sorry, yes.
Are they travelling out to the patients, or are the patients coming into the hospital?
I think previously it was much more with people coming into clinics, but I think they do come out to see people in Lyme and in Bridport and other local areas. And I think because often it's not easy for some people to get out to come to a clinic, particularly coming all the way, say to Dorchester.
Particularly with Parkinson's, the disabilities that people suffer.
Yes. Yeah, so I think the aim would be for people who are able to come into a clinic, say, and we do run a clinic in Bridport, but people who are able to come into a clinic, they would come in, but if people can't, then the nurses would come and see them at home. And I think we're much more in a position to do that now. So yeah, and that's why I think things like this are really helpful, because we get an idea of what people really need, and also having a telephone number, an email address, that you can get in touch with your Parkinson's nurse or Parkinson's doctor at that time. Oh yes, yeah.
Yeah, just on that point, I just wonder, have you got any sort of guideline as to sort of frequency of contact, or is that sort of very much up to the patient themselves?
Yes. No, well actually, I mean, the original guidance was that you would see somebody for your Parkinson's in person every 6 months, so usually alternating between, say, seeing the Parkinson's nurse, and then 6 months later seeing the Parkinson's consultant, and then 6 months after that seeing the nurse. And I think we've to be honest, we've not been meeting that at all, really, to be honest, and that has been a real problem, I think, and that's
is there scope for actually writing that down and giving that to the patient?
Yes.
That this is what you can expect. It may be already done, I don't know if it is.
Yes, no, and I think that's something that we should...
I feel there's a sort of lack of what to expect.
Yes.
In a written form. Or...
Yeah, and I think the reality, I think things are a bit better now, but the reality over the last 4 or 5 years, we've had 2 Parkinson's nurses when we need 4 across West Dorset, and just not enough medical time for the clinics. And I think we are building up on that. But I have to be honest, it's not been as good as it should have been anywhere near, really. So ideally, we would see people every 6 months or so, but in the earlier stages, say if you've been recently diagnosed or first diagnosed, then we should probably be seeing you a bit more frequently. Oh, yes.
Access to other services like the speech therapists and the other sort of therapy areas. Yeah.
Yes. Yeah. So, I mean, and we have access to physiotherapy, occupational therapy, speech and language therapy, dieticians, and yes. And there was some talk previously about people with Parkinson's being able to just self-refer. So if you're say struggling with your walking or mobility and feeling less steady on your feet, then you can then we feel, and the nurses feel, that you should be able to just self-refer to a physiotherapist. Partly because people often, you'll know because often at the early stages with Parkinson's, people are generally pretty stable on their feet and don't usually start having numbers of falls for a good few years in. So if you are feeling less steady, or your walking is getting more shuffling and less stable, then we feel that you should be able to just self-refer to a physiotherapist rather than waiting for X number of months to see somebody.
So how would you know who to approach for that? Self-referring to physiotherapists is like sort of in and out.
Yes. Yeah, and I mean the closest access that we usually have is with the community rehabilitation teams. So each community hospital or each locality has a community rehabilitation team which will have physiotherapists, occupational therapists. They'll link in with us, with the Parkinson's nurses. So, what we're looking at doing much more now is actually referring people on to some of the specialties at the first presentation, because often, and if you don't mind me talking a bit about just with often when we first see people with Parkinson's, usually at that time you may well have had symptoms for 2 or 3 years, sometimes 5, 6+ years, and the changes in the brain often start probably 10 years before we notice much in the way of significant symptoms that affect people's quality of life. So by the time we see people, actually you're probably at the stage where you would benefit from seeing a physiotherapist. I think so. Again, what we would like to do is when we first see people and say we think you're likely to have Parkinson's, we're starting you on some treatment, refer you to a physiotherapist and probably an occupational therapist at that time. And if you're having any speech difficulties or any sort of slurring of the speech or any softer speech that is a bit difficult for some people to hear, I think but I'm quite softly spoken generally. But then that's probably the time to start seeing a speech and language therapist. So, and perhaps it might be something that we could link in with yourselves from Parkinson's UK, because I know a couple of the team, and I think Heidi and a few of the team from Parkinson's UK were quite keen on just starting the process and referring at diagnosis rather than waiting for 5 years. So that's something that we could probably talk about and potentially look at integrating that both with the plans for follow-up, saying we'll see you after diagnosis after 2 or 3 months, and then we'll see you every 6 months, but you can get in touch and we can see you sooner if need be. And I think I'm hoping that over the next year or so we should be in a position where we can offer much more regular and consistent appointments, because as I said, I think the last sort of 4 or 5 years hasn't really been good enough from our side. And probably in Lyme, and I think probably in Bridport as well, because you're a little bit further away from the hospital, our service is probably less good or less easy to access. Oh yeah, do have a seat, sorry. Oh yeah, do have a seat. Oh yeah, and let me know, so my voice is probably not all that strong, but yes, hiya. Yes, so there's, I think, one of the big things that I was going to sort of talk about at the beginning was some of the things that we've tried to do over the last few years, but also some of the areas that aren't quite good enough in terms of the service we provide and what we would like to do over the next few years. And probably quite a lot of that needs to be guided by people who have Parkinson's and relatives and friends who see gaps in the service and what would be ideal.
So how do we feed our thoughts into that process? Through the PPGs and such as surgeries, or direct to the nurses? Or?
Yeah, I mean, I think it's quite helpful, like direct to the nurses from here, but also, I mean, also us sometimes coming out to your events like this and like other ones, because what would be really good, and we have some contact with the Parkinson's teams and Parkinson's UK in Dorchester and some in Blandford, but having people involved from either through Parkinson's UK or just through the nurses or myself communicating and saying, look, I've not had an appointment for 2 years, how can that happen, or what's going on there, that things should be a bit better really. Yes. Oh yeah.
Mainly funding the problem with the number of nurses or also supply, aren't there enough nurses, aren't there?
Yes, I mean, I think it's quite a bit of it is funding, although, I mean, the money is partly there. I think sometimes it's getting the trusts to spend that money that is there for the Parkinson's nurses, but also the NICE guide, the National Institute of Clinical Excellence. They used to have a guidance about the number of patients per Parkinson's nurse, and I think it was at one point it was 300 people with Parkinson's per one nurse, and I think most of us felt that was probably slightly too many patients. But in an area like this, it would be more like 250 patients or 200, because it's so rural. And yes, so it's partly the funding. It is also appointing and recruiting the Parkinson's nurses. But actually, we have found when we've advertised, people do apply for the jobs, and I think some of it, which we've spoken to the Parkinson's UK team, is actually having a firm guidance because the NICE guidance and the Parkinson's UK guidance isn't set in stone for the trust, so it's a recommendation. So they recommend that you have one nurse per 300 people with Parkinson's, but that's not, they don't get penalised, or there's no outcome if they don't do that. And some hospitals, certainly not so much in Dorset, but outside Dorset, some Parkinson's nurses have 800, 900 patients per nurse, which is totally unmanageable. Because for me, that would be like having, if you have 3 times the number of patients that you're supposed to have, you just cannot do your job properly.
I suppose Parkinson's UK, they spend on research, they couldn't fund another 2 nurses.
Oh no, they do they do something called pump priming the nurses, so they will pay the Parkinson's nurse salary and training costs for the first, I think it's the first year, but maybe even the first couple of years. So they do fund sort of clinical posts, but it's not. Then it should be funded by the trusts, because really it's not. We shouldn't be having to fund posts through a charity. We know that they're needed, so they should be funded by hospitals and things. So, and a lot of the outcomes, we know that the outcomes for patients are much better if you've got a good Parkinson's nurse, and that nurse has got, say, 250 people with Parkinson's on their caseload. The outcomes are, your outcomes are likely to be better because you get a more dedicated sort of service. So probably something that we could potentially jointly do is through perhaps Parkinson's UK and your and local work with Parkinson's in Lyme Regis is writing, say, to the chief executive or to the MP, and to say, actually, we would really value having say one Parkinson's nurse for 250 patients, because that's what we know is the best sort of ratio, but that rarely happens, and we're a bit closer to achieving that now with both Carol Walker and Lisa Green. So I think we're in a slightly better position than we were, say, a couple of years ago. But I thought I'd just mention briefly about a few of the things that we've done in West Dorset, and then just a couple of the challenges, and then if there's any things that we could just talk between us with a few questions about how things run, or I could talk a bit about some of the newer treatments for Parkinson's, if that would be helpful. But some of the things that we've really tried to do, and when I first started working in Parkinson's, the big things that I've recognised, and probably the most important thing really, is that having with all of the patients, with all the people with Parkinson's, having good access to the services. So, and probably the Parkinson's nurses are the most important bit of the service really, and the medical side needs to be there, but I think that the nurses are probably the most important bit. And so, do come on in. Yes. We're just talking a bit about the Parkinson's service in West Dorset, and so some of the things that we had one of our nurses, unfortunately, was very unwell a few years ago, and so we had a long period when one of the team was on long-term sick leave, which left again just not enough Parkinson's nurses there and dealing with the patients. So at that time we had to reduce our input to the ward. So when people come into hospital and they've got a known diagnosis of Parkinson's, it gets flagged up to the nurses, and then they will automatically go and see them on the ward to make sure they're okay, check they're getting their medications on time, that they're getting it at the right dose and the right time. But unfortunately we sort of pulled back on that quite a bit a few years ago, and in the last couple of years we've managed to fully reinstate that. So now Hazel Coleman and Maria Irving Scott and Carol Walker all provide some sessional time to the hospital. So any people who come in who've got a previous diagnosis of Parkinson's, it's logged onto the system, and as soon as they come in, it gets alerted to our secretaries, excuse me, to our secretaries, but also to the Parkinson's nurses. So they will review what's been happening, see what they've been brought in with, and then they'll go and see those people. And that's something I think we're quite proud of, really, because it's so important because Parkinson's is quite a complex condition, and there are lots of things that can that when people come into hospital can go wrong. And I think sometimes that is our sort of issues with our management in the hospital. So people not being given their medications on time, people being given the wrong dose when it's prescribed, but usually we find that if that does happen, we can redress that and sort it out early on there. So we've put in regular review of people with Parkinson's in hospital, and also the nurses do a sort of ward round of all the patients, all the people who've come in there, and I think we feel that sort of proactive approach is really important, because we don't want to sort of get a week into somebody's admission and they're on the wrong dose of their medication, or they're not getting it regularly. And a couple of other things, just when people are in hospital, sometimes we have people coming in for operations, and particularly if they're having an operation on the bowel, or they're not able to swallow their normal tablets, then sometimes we would arrange to put in a nasogastric tube to give them their medications in dispersible form. Or we have a patch called a retigotine patch, which is a dopamine agonist that just literally goes on the skin, and then it to some degree it replaces the dopamine that's missing there. So and those sorts of things, not everyone will necessarily know about or address early on, so we just get on and address that with the team that's looking after them. So I think that's been one of the big things. Our Parkinson's nurse numbers are much better now, so I think we're not far off the stage where we've got about one nurse for about 250 patients, which is better than it was. And I was just talking, we were just talking a bit earlier on about running some newly diagnosed sessions. So, and these we've run, I think, one in Dorchester, and we're going to run one in the Blandford area. But I think it would be good to look at running one in this area. I think partly because it's a bit further out, lots of Lyme and Bridport way, and all we do, we link in with, and they're really jointly run by Parkinson's UK and ourselves, but we have some of the nurses from Parkinson's UK, usually one of the doctors from the team, a physiotherapist, an occupational therapist, a speech and language therapist, and someone from Parkinson's UK as well. And so we just talk a bit about if people have had a new diagnosis of Parkinson's, or if they've been seen in clinic and we say we're not sure if this is Parkinson's, it might be, we'll give a trial of treatment. And it's just trying to demystify some of that and explain to people what's going on. But most of it is actually, excuse me, most of it is to allow people to sort of ask a few questions and run through a few details together, and they are such valuable times, I think, because the nice thing is I think you get to meet a lot of people who are involved with the service and patients, and also people can then they know that they can get in touch with me or one of the other doctors or one of the nurses and say, look, I'm a bit concerned about this. My swallowing or my speech hasn't been normal, it doesn't feel quite right, what's happening? And often through the speech and language therapist there are lots of techniques that they can use that can really improve those things. So with speech and swallowing, it's a similar thing to some of the muscles. You get some slowing down of muscular movements and changes. Oh, thank you very much. Oh, thank you.
Pleasure.
Thank you. Thank you. Thanks. So you get some of the slowing down of those muscles in the same way that you can of muscles in the arms or the legs, or some of the muscles of breathing. And often there are techniques that the speech and language therapists can use to help re-strengthen those muscles or help them to move more effectively. And often I've seen a few people who I've sort of struggled to hear even when I'm sitting next to them in the clinic, because their voice is very soft. And then a few months after having seen one of the speech and language therapists, they've just managed to recruit different muscles within the pharynx and around the voice box, and people's speech can improve quite dramatically without any new sort of fancy drugs or treatments there. Yeah, so I think the newly diagnosed groups, I think we should probably look at setting one up locally. And partly it's just a little bit like this. Then you've got access to people, and if there's things that people can ask me things, and if there's things that I don't necessarily know, I can always ask colleagues from neurology or one of the nurses there and get back to people.
And how would we go about instigating that going forward? Would we talk with Heidi?
With it would probably be what I'll
From the local group, through you or through Heidi?
yeah, well probably perhaps myself and Heidi. When I get back today, I'll email Heidi, because she's been the whole Parkinson's UK group have been brilliant because they also fund the sort of the venue for the places that we've run these groups from, and have done quite a bit of the organisation together with the Parkinson's nurses and ourselves. So it's something that we could I can pick up with yourselves and Heidi, because I think that would be, and some of it is also just having access, knowing that you do have access to the team, and as I think you were saying, having a nurse in one county, a GP in another county, a consultant somewhere else. We try and make sure that the medical team and the nursing team, the Parkinson's nurses, are working in the same place, because every week I meet up with the Parkinson's nurses and we talk through any issues we're having, and it's a bit of a way of getting mutual advice, but any concerns about patients they have or I have, we'll bring up together and discuss. So you need to be working in the same area and meeting regularly, I think. And
that's actually quite a challenge around here. You know, when you talk in a local group, very often they say that they're seeing a consultant in Exeter and the nurse is here in West Dorset, and it's very difficult.
Yes, and it is. I think it's particular because we find it, because we're quite close, I guess, to the border of Somerset as well. And so with Yeovil, sometimes someone might see a gastroenterologist in Yeovil, but they'll see us for their Parkinson's. And I mean, sometimes getting around that, we do sometimes reallocate people. So sometimes patients who've been previously seen by a neurologist, say in Yeovil or in Exeter, they might, if it's convenient for them, they might move for me to look after them, and then they'll have the nurses in the same place. But it does depend a lot, because sometimes you need a neurologist, because I'm more of a sort of I work mostly in medicine for older people and general medicine. So if you're someone with younger onset Parkinson's, then it's probably better for you to be seen by a neurologist rather than, say, me. But in some cases, we do look after a lot of similar things. So, yeah. But I think ideally having the nurse and the neurologist or the geriatrician in the same hospital is ideal, really. But yeah, it's not that easy. Yes, yeah, and I'll make sure you've got my email and details. And also I think one of the other things that I was just going to talk about briefly is just having access to your Parkinson's nurse and say Parkinson's consultant. And I'm always quite keen on just having an email exchange between. So say if I've seen somebody who we think has a new diagnosis of Parkinson's, then getting people started on the treatment, and then I'll usually give them my email address and they'll let me know how things are going. So if in a couple of months, quite often people will email back and say actually things are much better with the treatment, with the levodopa or the Madapar or Sinemet, and that's really helpful to know, because then when I see them again in the clinic, it's useful to know. But how do you all feel about sort of ease of access to people and how you get information?
I've certainly found emails at critical times as things develop. Email exchange is very useful.
Yes.
I've been able to summarise how I feel I'm doing, and without having to make an appointment.
Yes, and I think some of that, it can be that you could have a few email exchanges and then avoid an appointment, but then have an appointment again in, say, a year's time rather than 6 months. I mean, some people email doesn't work for so well, but I think we probably should open up access a bit more to either email and we do have a sort of a general, for Dorchester, a general email address, so which is just Parkinson's at dchft.nhs.uk, which you can access for people with Parkinson's can access, relatives can access, GPs can, which is quite a good sort of general point of access there. I was just thinking, how are we doing for time? Yes, yeah. Yes. Oh, yes, yes.
Can I ask?
Yeah, of course.
I'm a physio.
Ah, yes.
It's great to hear that you're going back out towards, so these people that are coming in with other conditions, other problems into hospital, and you're actually going on and finding them.
Yes.
And that's fantastic. However, we recognise that during an acute episode, something going on that can have a huge knock-on effect with Parkinson's symptoms
Yes.
on discharge. So how is the access to ongoing support in the community following discharge? Do you have physios out there? Do you have people that can follow up?
Yes, yeah, and again, we quite often access that through the community rehabilitation teams there, and quite often, if people have been admitted, then either ourselves or the Parkinson's nurses will follow things up with them in the community. But I think, yeah, it might be, that's probably an area where we need to do things a bit better, really, because as you said, often when people who have Parkinson's, just because of the nature of the condition, if you have a bad chest infection or pneumonia, if you're in your 50s, 60s and reasonably fit and well, you probably bounce back in a few weeks. But with Parkinson's, it often takes much longer to recover. But often people do recover, it just takes a bit longer. And having some more proactive physiotherapy, occupational therapy in the community would be really beneficial there. Yes, yes. So I don't want to run into anyone else's time.
Well, I can come on a session a bit later on anyway.
Oh, yes. Yeah.
Do you know what time it is, Kate?
It's 1:10.
Oh, yeah, because if you...
James will be back at 2:45.
Yes. But I can leave my... Perhaps if I'll leave my email address and our Parkinson's... Dorchester Parkinson's email address, so do get in touch. And mainly if there's any things that either person, if you've not had early enough follow-up, myself or the team can arrange we can arrange earlier follow-up. Also, if there's any things that we should be doing slightly differently, that would be helpful to know. Yeah, brilliant. Thanks very much. Thank you. Thank you.